In recent years, the term gender-affirming treatment has become a point of public controversy, often discussed in spaces that are far removed from scientific evidence or the lived experiences of transgender and non-binary people. Much of what is said about these treatments is not only inaccurate, but also deeply harmful. Misinformation spreads quickly and often comes from political, ideological, or religious agendas that seek to delegitimize the needs and identities of transgender individuals. The result is a hostile environment that fosters discrimination, fear, and systemic barriers to healthcare. One of the most widespread myths is that gender-affirming treatments are administered hastily and without proper medical oversight. This idea assumes that trans people are confused or impulsive and that healthcare professionals lack ethical judgment. In reality, gender-affirming care follows well-established international guidelines, including those from the World Professional Association for Transgender Health, PATH, and various national medical organizations. These protocols include psychological evaluations, clinical interviews, informed consent, and individualized support tailored to the person's age, needs, and goals. Affirming care is not about rushing anyone into treatment. It's about recognizing and respecting the person's identity and providing safe, evidence-based options. Another harmful myth is that young people are being coerced into medical transition. This narrative is often fueled by fear and ignorance, suggesting that minors are being manipulated by activists or pressured by peers. The truth is far more complex. Most gender-affirming care for youth does not involve medical or surgical intervention. Instead, it consists of social support, counseling, and, in some cases, puberty blockers, medications that delay the onset of puberty to give the young person and their family more time to explore their identity. These blockers are reversible, have been used for decades in cases of precocious puberty, and are prescribed only after thorough assessment. The idea that children are transitioning overnight with no oversight is a fabrication designed to provoke moral panic. A related myth is that people who undergo gender-affirming treatments will inevitably regret their decision. While regret is possible in any medical treatment, studies consistently show that the rates of regret among those who access gender-affirming care are extremely low, much lower than many common procedures, such as cosmetic surgeries or joint replacements. When regret does occur, it is often tied to external factors like family rejection, discrimination, or lack of access to continued care, rather than the treatment itself. The myth of widespread regret is used to discredit the legitimacy of transgender identities and to justify denying care, despite overwhelming evidence of its benefits. Another frequent misconception is that gender-affirming surgeries are performed on children. This is simply false. Genital surgeries are not performed on minors, and other procedures, such as chest surgeries, are considered only under strict medical and psychological guidelines and, typically, after the age of legal adulthood. Opponents of trans rights often conflate gender-affirming care with medically unnecessary surgeries performed on intersex infants, which is a separate issue and one that many human rights groups have condemned. By confusing these distinct situations, they blur ethical boundaries and distort public understanding. Some claim that gender-affirming treatments are experimental or unproven. This is misleading. Hormone replacement therapy, HRT, puberty blockers, and gender-affirming surgeries have been studied for decades and are supported by extensive medical literature. They are endorsed by major health organizations, including the American Medical Association, the American Psychiatric Association, the American Academy of Pediatrics, and the Endocrine Society. These treatments are not experimental. They are medically necessary for many transgender individuals and have demonstrated effectiveness in improving mental health, reducing distress, and enhancing quality of life. Another dangerous myth is that being transgender is a mental illness and that affirming someone's identity is enabling delusion. This belief is rooted in outdated psychiatric models and ignores decades of progress in understanding gender diversity. Being transgender is not a mental disorder. What causes suffering in many trans people is not their identity, but the stigma, rejection, and barriers they face in society. The most effective way to support transgender individuals is to affirm their identity and provide access to appropriate medical and psychological care. Denying their reality only increases the risk of depression, anxiety, and self-harm. There is also a persistent myth that gender-affirming treatments sterilize people and that this is part of some ideological agenda. In truth, any medical intervention that affects reproductive capacity requires careful counseling and informed consent, just like any other treatment with potential fertility implications. Many trans people choose to freeze sperm or eggs before starting certain treatments, and they are given the opportunity to make those decisions based on accurate information. There is no secret plan to eliminate reproduction. What exists is a commitment to bodily autonomy, including the right to prioritize one's mental and physical well-being over reproductive function. Another common lie is that access to gender-affirming care is a form of indoctrination or social contagion, especially among youth. This notion relies on the false idea that transgender identities are a trend or a phase, rather than a legitimate expression of self. It also ignores the fact that trans people have existed across all cultures and historical periods. Increased visibility does not mean increased fabrication. It means that more people are finally able to name their experience and seek support without fear. Social acceptance enables honesty, not confusion. Critics also claim that people detransition in large numbers and that their existence invalidates the experiences of those who remain happy with their transitions. While detransition does occur, it is relatively rare and often the result of external pressures, such as family rejection, religious condemnation, or threats to personal safety. Most people who detransition still identify as transgender or gender diverse and would not have chosen to stop treatment in a more supportive environment. Weaponizing their stories to attack gender-affirming care is disingenuous and fails to respect their complexity. One of the most cynical myths is that gender-affirming care is a profit-driven industry exploiting vulnerable people. While it is true that medical care involves costs and that some pharmaceutical companies profit from medications, this is true of virtually every field in medicine, including diabetes treatment, mental health care, and cancer therapies. Singling out gender-affirming treatments as uniquely corrupt reveals more about the critic's bias than about the reality of healthcare systems. Furthermore, many trans people face significant economic barriers to care, and the idea that they are being overserved by a powerful medical lobby is a distortion of the truth. In fact, access is often limited, not excessive. Another myth is that trans people who receive treatment become more mentally unstable. In contrast, numerous studies show that access to gender-affirming care significantly reduces depression, anxiety, and suicidal ideation. Denying care is what correlates with poorer mental health outcomes. The myth of increased instability after treatment is a projection of transphobic assumptions onto a population that has consistently demonstrated resilience in the face of systemic violence. Finally, some argue that gender-affirming treatments are unnecessary because trans people could simply learn to accept their body. This narrative ignores the fundamental nature of gender dysphoria, a deeply rooted distress caused by the mismatch between one's gender identity and physical characteristics. While acceptance of one's body is important for everyone, telling trans people to accept what causes them profound suffering is not therapeutic, it's abusive. Just as we would not tell someone with a serious medical condition to learn to live with it when treatment is available, we should not dismiss the needs of trans individuals seeking relief through established medical care. All of these myths have one thing in common. They aim to delegitimize trans identities and deny people access to care that has been proven to save lives and improve well-being. They rely on fear, misinformation, and moral panic rather than facts, science, or compassion. Combating these myths requires clarity, precision, and a commitment to truth over ideology. Gender-affirming care is not new, reckless, or harmful. It is thoughtful, regulated, and deeply necessary. It is not driven by ideology or confusion, but by the recognition of human diversity and the ethical obligation to reduce suffering. It is not a threat to children, families, or society. It is a form of healthcare, one that, like all medical care, must be guided by evidence, respect, and informed choice. What is truly dangerous is the attempt to erase, pathologize, or criminalize the lives of those who are simply trying to live with dignity. The real harm comes not from hormones or surgeries, but from the laws, policies, and cultural narratives that make it harder for people to exist. Myths are powerful when repeated enough times, but facts remain facts, and reality does not bend to ideology. Transgender and non-binary people deserve healthcare based on truth, not myths. They deserve protection, not persecution. They deserve to live, not just survive. And the first step toward that future is telling the truth, without shame and without fear.